certified running gait analyst course with Doug Adams. Basically made a part 2, really focusing on the gait analysis aspect of it. So when completing gait analysis, it's definitely best performed on like a treadmill. Sprint treadmill, I'm not sure how great that would be. You still could definitely do some of it on there though. His whole thing, like he's got like a 3D imaging setup that he does where he puts sensors, and it's this real expensive apparatus. It's not very practical, but he also goes through a 2D analysis. So that's mostly what I focused on with this presentation. One main thing is that gait should be observed from the frontal plane. So checking out the front of them and the back of them, as well as the sagittal, so looking from the side. All 3 of these different views are going to give you a little bit of information on what's going on with these populations. Slow motion on iPhones, super important, as well as apps like Huddle and Coach Now, because with those you can draw some angles and kind of get an idea of where the body is in alignment while they're running. You could also set up a tape measure on the side just to get an idea of like their step length and just overall measurements. So with the course, they basically break gait up into 5 main categories of typical impairments that you see with people. These sometimes can happen in isolation, the primary ones listed here, but oftentimes there's multiple going on at one time, and with that you got to just be careful that you're not just focusing on one. Just going back through it, the 5 categories are overstrider, collapser, bouncer, weaver, and glute amnesiac. So the overstrider is the first one, and when I met Doug Adams at CSM, he actually had me like go on his 3D like sensor treadmill, and he found out that I was an overstrider, so this kind of applies to me. It is the most common, and it's seen at initial contact in the sagittal plane view. So essentially what's happening is when they're landing, their heel is landing right, like too anterior in their knee. It's supposed to land right under their knee, so there's not as much of a braking force. It goes right into backward propulsion. Also, some cutoff values for this would be a foot inclination of greater than 15 degrees, tibial inclination of 5 degrees. Both of those are pretty hard to like actually see just with the naked eye. And then strike from center of mass of greater than 28 or 29 centimeters. That's easier to see. You could use like a tape measure or just estimate with like one of those apps. So how to identify this? You're gonna often see with these people them having a low cadence. Low would probably be like lower than like 160 steps per minute. Also, like I mentioned, the strike from the center of mass greater than 29 centimeters. Foot inclination at initial contact will probably be a little high, so you'll see the foot, the toes like raised. Knee flexion can be seen, will be excessive. And one of the good ones to use, especially when using like one of those apps, is the malleolar line. So you essentially just draw a line up from where the malleolus is on initial contact. If it's anterior to the knee, they're probably an overstrider. So with this running style, people are going to have increased strain on the patellofemoral joint, patellar tendon, tibia anterior, posterior, femur, hamstrings, plantar fascia, hip joint, and the Achilles tendon. And some of the impairments that you'll see during their exam are just like their deficits with movement are going to be poor hip extensor strength or hip flexor immobility. These can prevent a neutral trunk lean, poor core stability, and then poor quadriceps or gastroc-soleoc strength. And that's going to limit braking during the overstriding. So when working with these patients, the goal is to shorten their step length while maximizing flight period. This is important with a lot of the cases. So a big, like kind of like almost like a cure-all, is going to be increasing patients' cadence. With this, a lot of people will instantly just start running faster. That's not really what you're trying to get. You're trying to increase the flight phase rather than just going faster. So you also want to place emphasis on extensor motor control and promoting the knee drive forward while they're running. So for a warm-up, you're just going to do a basic warm-up. You can do like knee hugs, a little heel raise just to get the gastrocs in as well. Ankle grab, same thing. Little heel raise. You can do sit switches, also dead bugs, get the core involved. So the main drill is going to be marching. basically like you're kneeing a soccer ball, you're gonna be focusing on just a knee drive forward, and you can go forward with that and just do repetitive knee drives. Then you can switch them up so you're doing like an exchange. You can do all types of things with that. You can do them close to a wall and kind of like have like a point where you drive to. And then you also want to attempt to correct posterior lean and excessive posterior kicks. That would be kind of like butt kicking. The next one is the collapser. Another super common one. It's good to appreciate this one, the frontal plane in the anterior and posterior views. It's characterized by foot pronation, internal rotation of the tibia, abduction of the femur, and potential circumduction during the swing phase. Oftentimes you're going to see rubbing of the skin between the knees, medial heel wear, and a report of their heels clicking from time to time while running.
What do you mean rubbing of the skin between the knees? Like
so you'll actually
together?
see in this one, yeah. So one of the main things to identify, what's up, Jim, is a narrow knee window, and that's basically that space between the knee while they're running. It's going to be super narrow or even rubbing up against each other. So that's where that knee rub will come from. Also, you'll see excessive eversion on the rear foot, potential of a Trendelenburg sign, because they typically have a poor motor control in that frontal plane. Hip adduction in the stance phase, then excessive knee flexion in mid stance.
You say that knee rub's common, or just the narrower stance is common?
So you might see knee rub, it's not always going to be, but typically with this gait style, you'll see that narrow window. And that's seen in the picture on the right.
Yeah.
So with this one, it's going to be increased strain in the patellofemoral joint, IT band, tibia, femur. You might see some femoral acetabular impingement, Achilles tendon pain, posterior or tibialis posterior, stress, piriformis, medial knee, gluteal tendon. With this one, some impairments you might see at the exam are reduced ability to properly perform a deep squat, generally like limited by dorsiflexion and excessive pronation. You could also see some poor core stability, especially in the transverse plane, poor quadriceps and generalized hip strength, and poor glute med and oblique strength. Working on a program with these people, we're going to want an emphasis on extensor motor control. So with the warm-up, it's going to again be a dynamic warm-up. Basically, most of these are. With this one especially though, you're going to want to try and get that posterior chain engaged, as well as do some hip abduction holds just to get a little activation there. So the main drill for this one is going to be the wall drill, which is what we call a triple extension. So getting on the wall, giving a lean forward, driving the knee up. You're going to start off with this one with just a postural hold, like holding that position. Then you can move to single exchange, double exchange, triple exchange, then ultimately rapid fire. And then also you can work on a hip abduction isometric. I don't know if you guys have seen me do this one before, but you kind of have them on a wall, pressing into a ball, and then you can progress that to dynamically moving it up while holding it. That's just going to work on that glute med activation.
For the collapser, like, how do you determine, like, I guess it might not be the perfect question, if it's like hip related or foot related, or if it's just like static or rigid? You know how some people like kind of just have like that overpronation of the foot. Do you always like address would you go like address the hip first, or kind of like narrow down on the foot? How would you go about that?
Well, it'll probably be easier appreciated like when you actually see them running, because I mean it's gonna look similar with everybody. It kind of like collapses in like this. Yeah. But like if you see excessive, like very excessive adduction or very excessive Trendelenburg sign, like you might want to do more hip.
Okay.
So I would really say like that probably just comes down to like in the moment like what the person presents with.
Gotcha.
So this one, the next one's a bouncer, and this one is actually like out of all of them, I would definitely try and fix this when you see it with people, just because this gait impairment is characterized by excessive up and down or vertical oscillation while they're running. This becomes super problematic when it's paired with different other impairments such as collapsing, overstriding, or weaving. Basically bouncing, going up and down, especially over long periods of time, repetitive motions, it's going to add just extreme amounts of stress and exacerbate anything, or like I guess make worse any other of the other impairments. So with collapsing, it's going to make collapsing significantly worse. But overstriding, it's going to be putting a lot more force on those braking musculature. So also, it's very inefficient because with this gait impairment, you're essentially putting your force through the ground inferiorly rather than posteriorly, which we want to be putting our force posteriorly so that we can propel ourselves forward. Also, how to identify this? It's going to be characterized by 10 centimeters or more vertical oscillation, change of position of center of mass, reduced forward trunk lean, which is another one that's kind of like in all of these, ponytail bobbing excessively, and the potential of loud noise. So with their feet hitting the treadmill and it being really loud could kind of be a telltale sign. There's going to be, like when this is in isolation, there's going to be increased stress and strain on the tibia, brachial musculature, and the subtalar joint. In tandem with other patterns, it's going to exacerbate the stresses. And yeah. So key impairments for this one are going to be limited hip extension, generally from tight hip flexors, limited dorsiflexion leading to early heel rise, tight hip flexors limiting gluteal activation, and poor core and trunk stability limiting forward lean. So with this, our emphasis is on hip and dorsiflexion mobility and sagittal core motor control. Warm up going to be dynamic like the rest of them. Also get the hip flexors going with like a knee drive. The drills, once again, are going to be the wall drill. For this one though, you can put a piece of tape like right in front of like where their eye line is, and kind of have them use that as a visual cue. Try and reduce the amount of bouncing, just like through visual biofeedback. Also, this comes in with the resisted forward run, using that band, following them, because that can help promote the forward lean and work on placing those forces posteriorly. Also with this, treadmill running, we can't really do it in here with this. I guess we could with mile per hour, but just using it as a set speed, and this is really going to come into play when doing cadence training, because you want them to increase their cadence without increasing their speed, so they're not just like trying this out and burning themselves out. The next one is the Weaver. It's typically not seen in isolation, usually seen with overstriding and collapsing. Best appreciated in the frontal plane from both the front and the back view, and characterized by a crossover at midline with an initial contact of greater than 2 centimeters. It's important to also keep in mind that the faster they're going, the faster that we run, the more narrow we run. So it's just important to keep that in mind, just so you don't misdiagnose or misinterpret somebody's running style. So to identify this, we're gonna definitely pay attention to the foot in relationship to midline. If it's crossing over, they're probably weaving. Also, a greater degree of hip adduction. Paying attention to the rear foot at initial contact, there's going to be some supination. You might see lateral shoe wear, and then whipping of the arm, so essentially like excessive thoracic rotation, kind of like throwing themselves back and forth. With this one, you're going to see increased strain on the medial tibiofemoral joint, the plantar fascia, posterior tibialis, femur and tibia, 4th and 5th metatarsal and IT band. Some key impairments are going to be poor frontal plane motor control, glute med, limited hip extension causing excessive pelvic rotation, limited hip flexor mobility, and poor core stability causing hip abduction from the pelvis. So with the Weaver program, I got this nice little photo up here. We're going to be wanting to put emphasis on proximal motor control and anterior hip mobility. Warm-up's going to be the same as the other ones. The drill, once again, the wall drill is super important with this one. And for this one, it's good that you can put like a piece of tape lower, kind of have them aim with their knee, try and hit that piece of tape. Not obviously going to hit the wall, but just having it as a place to aim for. Also doing arm swing in long sitting. So this is going to force them to stabilize their trunk and lower extremities with their core rather than just passively whipping themselves back and forth. And then what he calls Charlie's Angels marching. So it's essentially getting the arms up like this and doing a knee drive and then kind of moving with that knee drive. It's supposed to keep the torso kind of more stable while you're doing this leg motion. Also the hip abduction isometrics are going to help with this one as well. And so the reason why I put this photo is because a good cue for these runners, like while they're getting back into running, is to use a line on the road, preferably the white one, to kind of keep their feet on the outside of. So for the last one, it's the glute amnesiac, and this is best appreciated in the sagittal plane. This ultimately is just talking about like poor trunk lean, so kind of like staying back, and it's often seen in patients who sit throughout the day. It's considered like dead butt syndrome. So like a lot of people work at desks, they're sitting all day. They kind of get like just passive like atrophy or like misuse of their gluteal muscles. This causes that compensation of kind of like leaning posteriorly, because it puts more forces into the quads. So they're essentially running with their quads more so than their posterior chain. So you can see this girl right here, she's leaning back. You'll see a forward angle of less than 10 degrees. You can also measure malleolus to hip. Initial contact, mid-stance, and push-off, there's going to be a greater angle in patients leaning backwards. And there'll typically be a bouncer as well. Increased strain in the brachial musculature, as well as the lumbopelvic hip complex. Then some key impairments. I just wanted to talk about why first. So, like I said, leaning backwards kind of increases the knee torque, which reduces the torque on the gluteal muscles and hamstrings, resulting in the quad dominant running that I previously mentioned. With these patients, you almost also might see limited lumbar mobility, poor core and trunk stability, limiting forward lean, and tight hip flexors, kind of a consequence of sitting all day. So a study actually found that a 6.8% increase in trunk lean led to a 6% decrease in patellofemoral joint stress, and a 3.3 decrease in trunk lean led to a 7.4 increase in patellofemoral joint stress. Basically just showing that a lot of like patellofemoral pain could be from this slight adjustment itself. With this program, we're focusing on posterior chain mobility and motor control. Warm-up's going to be hip dynamic. Drills are going to be the wall drill, focusing on maintaining that forward lean. Wall falls, so getting into a single leg position, triple flexion, kind of falling towards the wall just to appreciate yourself leaning forward and getting into that position. Catching yourself with your hands, not letting your knee smash the wall. And then resisted run to also push that forward lean going. So, just like some key points to take away from this, because you guys are definitely not going to remember all this. So just some analysis keys. It's good to observe everybody from all angles. It's important to utilize technology, so you get a better breakdown of motion. You can look back at it, put it in slow-mo. You can consider the presence of multiple gait patterns happening simultaneously. They're not always going to be in isolation. Asymmetries are pretty important to pick out, because actually for Jim, I saw he's kind of like he was a collapser just on his right leg though. His left leg was acting differently than his right. So people will identify with just like one leg presenting as like a collapsing type motion or what have you. Patient should come with running shoes, avoid baggy clothing, and tie hair up. And this is just so you have a better idea of what's going on with their actual body. If they're wearing super baggy clothes, you're not gonna really know what's going on. And then having a patient warm up and then running for at least 5 minutes prior to observing them, especially because they might just be like, well, like eyes are on me right now, I'm gonna try and do my perfect running. They might fall out of their natural form. So some key adjustments, and these are just like pretty vague, just things that I've noticed throughout his presentation. We're kind of on each of the programs for all 5 impairments. We're increasing cadence, and you want to be within like 160 to 180. That can be controlled with like a metronome app, just playing in your ear, trying to match your feet to the beat of the metronome, or with different music apps on Spotify. You should encourage a forward lean, just for greater ground reaction forces going in the right direction for forward propulsion. Patient might demonstrate reduced posterior chain involvement due to tightness of the hip flexors, which is often seen. So it might not even be that their posterior chain is just super weak. They could just have trouble getting into that position. And then address asymmetries. And so lastly, I just wanted to touch back on stiffness. I'm not gonna go crazy with this just because I was kind of like saying earlier, it's still kind of like a mystery. But the three main forms that I've seen them talk about with mechanical stiffness are leg, vertical, and joint stiffness. Currently, there's no longitudinal studies investigating the effects of strength or power training on mechanical stiffness levels. That was from an old piece of, like an old article. Found another one that basically said that all that stuff is still inconclusive. I'm not really sure what it does, like what the effect of power, eccentric, and strength programs have on stiffness. But essentially, stiffness is defined as a resistance of an object or body to change in length. The current idea is that mechanical stiffness in the human leg influences rates of force development, elastic energy storage and utilization, ground contact and flight times, as well as stride length and frequency. So it's measured in a couple different ways. There's a bunch of like dudes a lot smarter than me trying to figure out like the best way to measure it. For the sake of like, if you guys ever wanted to do it in here, it can be done with force plates and with video. Video is still limited by frame rate, just because especially if somebody's running fast, don't really know what's going on if you have a low quality camera. And so how it's measured, and this is getting into some like physics stuff that we really don't need to go too crazy on, but essentially like K leg is stiffness, F max is the maximum amount of force, and delta VCL is the change of leg length derived from video analysis. That's one way of doing it with a camera. Then vertical stiffness is usually calculated with the McCann and Chen method, and that just uses force plates, and that's just max force and divided by the change in maximal vertical displacement center of mass. Both, I don't really know. Like pretty complicated stuff. But utilizing stiffness, so essentially they still don't know really what affects it. But they have found that in mid-distance runners, increased leg stiffness appears to be linked to more economical or less metabolically demanded running. In the same study, they found that there's the strongest relationship with this is plantar flexion joint stiffness, so at the Achilles, and this is found to improve running economy. So my thoughts on this is that because they still have no clue like how strengthening affects it, I have a feeling that it's probably more so related to neuromuscular adaptation and kind of just like mental changes in like, how you run. At the same time, I don't think that you could maintain stiffness or utilize that principle without proper strengthening. So I think it's important to work on isometric, eccentric, and concentric strength with runners. And then finally, prior to attempting to implement these principles, I would definitely look more into it because it's still kind of like cutting edge, like newer research. There's still a lot to be answered about it. That's all I got.
Tim?
Yeah, Tim. So on a day, Tim, where say you had a runner come in as a patient,
Yeah.
right? You talked about like throughout the presentation of like exercises you could do, cues that you could watch for on the road, warm up, drills. How would you tell them to implement from like A to B, all of that stuff, and then like say they were running that day as well? Like what would maybe be a schedule or like a routine or something look like?
So the course did provide like a running schedule,
Okay.
and a lot of it goes off the principles from the last one, where it's supposed to start with like, so like 80% of your runs are supposed to be low intensity, high duration.
Yeah.
And then moving into your speed work around like 20% of your training days. The one thing is that I also read in there was that when you're switching somebody's form, it's important to drastically reduce the volume at which they're running, because but also just reducing the force because they might kind of like feel some different aches or pains just with everything aligning differently.
Well, like, what about like the order? So like, so say they were coming in, say it was a Wednesday, and they were coming in, and they're coming to physical therapy first. How would you would you tell them to maybe do the exercises first, then the drills, then warm up, then run, or to be like I'm kind of saying like
I
so
get what you're saying.
yeah, so like if just say a baseball guy was coming here and he was Tommy
Right.
John, we'd go to like physical therapy, so I'd be like I would do motor control work first, and then I would probably do like some low level plyometrics, then I would probably get them warmed up and then throw.
Yeah, I was about to say, I would probably start with a warm-up, kind of address some of the limitations that were in those. So, say they have, poor motor control, poor hip mobility, or poor posterior chain activation.
Yeah.
Work on those throughout the session.
Okay.
Then start hitting those, wall drills or resisted running.
Okay.
Then hop them up on the treadmill and kind of try and implement what we just did in the core drills and get them working on them on the treadmill. From there, if they were running later that day, I would say, say they typically run a 5K a day
Yeah.
or what have you, have them run a mile.
Okay.
But just focus on keeping the form right
Yeah.
and then slowly progressing from
Yeah.
there.
Yeah, I just had a question. Is there? I know you said you use the metronome for somebody who's an overstrider, where you don't want them to run faster necessarily, but want them to increase their cadence. Would there be a certain kind of cue or something when you're actually working with them, actually running, that you might implement besides a metronome or something like that? Can you talk anything like that?
That's
Because that was the first thing that I
Yeah.
thought of, increased cadence, run a little bit faster.
Yeah.
Right.
Just wondering how.
Yeah, kind of
it's
link.
hard
I
to-
linked them up in my head to link them, but they're not
It is
linked.
tough.
Yeah.
Yeah. Because even when I was at his thing and he told me he's you should increase your cadence, so he set the metronome up, and with the metronome it's kind of crazy how fast your brain adapts to you start hitting the
Okay.
beat pretty easily. But I feel I definitely sped up a little bit.
Okay.
I think it's just important to keep that stride length pretty short, or the step length pretty short, just so you can start putting more posterior force. It's definitely it's not an exact science though.
If you have a treadmill too, it'll help because you can keep it at that.
Yeah.
Yeah,
Whatever
that was-
is
so
easy,
that
but
was,
if
the
you
main
do that
thing, and that's-
outside, and have that in your ear.
Yeah.
That's
I
kind of
wouldn't get the same that I would
what I was
on the
touching on. It would be tough to do with this because
So
you can kind of look at how fast they're going, but yeah, treadmill is something good to do. Just right, so you can work on maintaining a consistent speed that's not excessive, while at the same time upping your cadence.
I think there's apps though you can set your speed too, and it'll on the watch, whatever, it'll
Yeah.
vibrate for distance runners. If you want to have an 8-minute mile, if you
for-
are going too fast or too slow from that,
I'm sure there's
I think there's
Cadence
things that can kind of be in your ear or
apps
vibrate.
out there because I
Yeah.
know there definitely is for cycling.
Oh yeah, there's metronome apps, and then like I was saying, on Spotify, there's different playlists where you can put 170 beat per minute
Yeah.
cadence.
Oh, cool.
And so it's got even Kanye West stuff. They got
Yeah.
all kinds of music,
Yeah.
and they're all at that beat, so you can kind of run to the beat. almost.
Okay.
Yeah.
That's cool.
Yeah.
What's the number again? 160 to 180?
What's that?
160 to 180?
Around 160 to 180. So the way they got that number was a collegiate females track race, a championship race, and they basically summed all or took the mean of all the girls' cadences, or one, and I think it was 180. And they're 180 is the where you should be running at, but
Yeah.
obviously that's one population. It's not
Yeah.
very specific.
Yeah.
And there's gonna be variations with height.
Yeah, limb length.
Level of running. So it all really depends, but usually speeding up somebody's cadence will kind of self-correct a couple things.
Cool. Great job, Sal. Awesome. What's up, Angela? You got yourself educated, buddy.
Yep.